the upper right, upper left corner, Emil Kraepelin, Eugene Bleuler, Nathan Klein, who is known as the father of psychopharmacology, Aaron Beck, the great man who passed away recently, and of course Robert Spitzer, who kind of overhauled the DSM, modified the DSM in entirety, was the editor of DSM-3, took away homosexuality from the official nomenclature, and so on. And when you read about the biographical pieces on these grades, then you start realizing that what is it that made them great? Perhaps it was great hard work. Perhaps it was a lot of wisdom. Perhaps it was the fantastic research that they did, and so on. And I think we get these kind of nuggets from them that help us grow as a psychiatrist. I might say that what I'm going to say is both brilliant and original, but there is a small problem that where it is original, it's not brilliant, and where it's brilliant, it's not original. Because if at all you find some good pieces, they are perhaps taken from grades like these. One point that has often struck me is something that we sometimes forget, that the most important goal of any first session is the patient returning for the second one. Now, when we first evaluate a psychiatrist, now let me again say that I'm addressing the juniors. I mean, the people like me who are in a learning phase, that when we see the patient for the first time, our focus is kind of on taking the history in detail, trying to elicit if the patient has hallucinations, what variety, are they really hallucinations, what kind of delusions, any first-rank symptoms, and so on, making a provisional diagnosis and writing a prescription and giving it to the family. But I think one very important aspect of our very first meeting is the therapeutic alliance. We have to ensure that the patient does come back for the second consultation, because if he or she does not, then I think there is something going wrong somewhere, either on your side or on the patient side. And I'm a great votary for doing kind of non-technical things that improve the alliance. For example, maybe cracking a joke with the patient when both of you can smile, both of you can laugh together. In fact, there was a study which showed that psychiatrists who laugh with their patients have a greater remission rate. Now, that's something fantastic. I found it really understandable and quite impressive. And secondly, maybe you can discuss with the patient something outside the clinical area, like the experience in the college and about the work environment and small things like those, the hobbies of the patient that we often don't ask about. So basically, if the patient starts liking you, I think that's a great job done. Because unless the patient likes you, he or she is less likely to keep coming back to you. So I think the first meeting, apart from the technicalities of the diagnosis and the management, I think establishing a therapeutic alliance is very, very important. It's important to remember that no meeting with a patient is ever routine for them. So it should never be routine for us. Now, think of a patient who comes to you once in a month, once in 3 months, maybe once in 6 months. So for him, it's a very special time when he's seeing his doctor, going to discuss things with the doctor. Now we, with the fair number of patients that we see, sometimes large numbers that we see, now we at times go in that kind of rut in which we go on doing things mechanically, almost in a very routine manner. But I think it's important to remember that for the patient, it is not routine. And so it's routine for us. It's important to be as empathetic, as caring, and as alert for the 10th patient as for the first. Now, this is something which is ideal, but not always easy to achieve. I mean, maintaining your alertness and your level of empathy throughout those 6, 7, or 8 hours that you might be working. And I think each one of us does find some ways of doing it. Like, to tell you, the ways I have found it is that somewhere midway in my consultation hours, I work from 10 to 6. So somewhere midway, I take a cup of coffee. I found that splashing my face with water once or twice in the working hours, that works wonders. Now, this is something that I discovered by chance. that you splash your face, you go to the washroom, splash your face from the sink, and after that, for quite some time, you are fairly fresh. And in fact, at times, I take a power nap in the middle of the clinic. Like I'll finish the first half, take a power nap for 10, 15 minutes. Power naps are helpful. It has been proven scientifically. You are more alert, your concentration is better once you take a power nap. So I think we have to devise our own means as to how to remain alert throughout those working hours. Because if we are not as alert for the 10th patient or the 20th patient as say the first, second, or third patient, which often we cannot completely, then our productivity is likely to go down. There are no bad or boring patients, but there are some bad and boring doctors. I think it's not rare to see psychiatrists commenting on how boring the patient is, how the patient is going on and on, how the patient is just not stopping. I mean, these things do happen clinically, but I think our being psychiatrist does demand that we empathize with people who speak less, we empathize with people who speak too much. And I think the skill lies in, kind of, let me use the term cutting down where it's important, and cutting down in a manner which is acceptable to the patient, which is desirable in the clinical scenario. There was a study done in Maryland, USA, and in that, many of the patients had voiced this, that psychiatrists are rushed, uncaring, uninterested, and in it only for money. Now, if you look at the adjectives that are used here, it's quite sad. And I think we always need to keep in mind, I think we need to keep on introspecting from time to time, that am I doing anything that fits into this description? Am I rushed when I'm seeing my patient? Do I seem uncaring? Am I not empathetic enough? And so on. It's important never to lose sight of the practical struggles the patient and the family faces in the real world, and try to help them find practical solutions. The family does face huge problems, we know. No need to enumerate them, difficulties with the patient's behavior, the challenges in maintaining a compliance with the medication and the visits to the doctor, and the visit to the doctor itself. I often encounter patients who, poor souls, they have traveled something like 12 hours, overnight journey, could not sleep at all in the train. In the morning, they had to rush to my clinic, afraid that they might miss the appointment, no breakfast taken. So if you look at things from this point of view, like this train shows the rush of people. And it's commonly this kind of scenario, the family patient and the family comes to us. And if the patient and the family have faced so much of hardship in coming to us, I think it's definitely prudent that we be kind to them, we be compassionate to them, we keep our own negative emotions in check. Negative emotions do keep on cropping up from time to time. There are patients who will provoke you, there are patients who will irritate you. They might provoke you into saying something that does not fit an ideal doctor-patient communication. But I think one has to give it to them. One has to keep in mind that they have been facing huge hardships, and they might have faced a lot of hardship in reaching you. Try to create rare magic moments, things you say to patients that they will remember and use in changing their lives. Very often, many of us use inspirational statements or motivational statements, motivational quotes for the patients. I personally find it quite useful, because inspirational statements are something that can stay with the patient for a long, long time, and they can keep on inspiring the patient. And you never know what would work with what patient. So I think it's always a good idea to have a stock of some inspirational quotes in your mind that maybe you can use from time to time, depending on the patient's unique needs. Like I have mentioned, one of my favorite quotes, which I often tell to patients who keep on worrying about the current life situation, that if it won't be a problem after 10 years, it's not a problem today. And I've seen patients who come back to me and thank me, डॉक्टर साहब आपने वो जो बोला था वो बहुत काम कर गया, आपने वो जो 10 साल का रूल बताया था. And sometimes even mundane things work. You do not expect them to work. One patient came to me and said to me कि डॉक्टर साहब मैं 15 साल पहले आया था आपके पास और आपने वो जो बात मुझे बताई उससे मेरी लाइफ बदल गई. मैंने कहा मैंने क्या बताया था आपको? आई वॉज क्यूरियस. सो ही सेज कि डॉक्टर साहब आपने कहा था चिंता करना छोड़ दो. बस उस दिन से मैंने चिंता करना छोड़ दिया. Now, frankly speaking, I do not believe that I would say such a simplistic statement. "Chinta karna chhod do." That's the kind of thing the family says. But for some reason, that stuck in the patient's mind, and the patient claimed that it changed his life. He stopped thinking. So, basically, what I mean to say is that maybe some inspirational quote thrown at the right time that often works quite well. There are some studies on why do motivational quotes work. Like there is a self-selection process, which means that people who tend to read the quotes carefully are the kind who are likely to follow them. So it's a kind of bias sample of people using the quotes. Then the power of the language, the kind of language, the way you frame your words. I think it's a foregone conclusion that in psychiatry, perhaps more than in other branches of medicine, you need to use a language which is measured, which is articulated very appropriately. Rhyming aphorisms, they often work quite well. Attractively balanced phrases like marry in haste, repent at leisure, they are the kind of things that stick in the mind and continue to work. And thirdly, words from recognized leaders. Now, we, by the patients, are seen as perhaps wiser than them, quite educated, experts. And as I said, in the case of my patient who said ki chinta karna chhod do, worked very well for him. So anything coming from us, that is taken quite seriously by people. So I think there is no harm in uttering single quotes, motivational quotes, that you can leave with the patient. The patient is quite likely to follow them. It's very important to take time and being careful. Small mistakes can have major consequences. Now, sometimes when we are rushed, sometimes when we are seeing the patients in assembly line fashion, I think each one of us has got to make some rules for oneself as to what are the kind of things that we must not miss. Like, for example, you tell the patient कि आप serum TSH करा के लाओ. Now, these days, it's very common. The patient goes back, and when it comes for the next visit, he brings a big bundle of some laboratory, some famous laboratory chain, and he has done the entire range of investigations, including serum iron, iron binding capacity, TIBC, and serum magnesium and calcium. And when you ask the patient कि इतना सब क्यों किया, a very common answer is कि डॉक्टर साहब वो पैकेज में मिल रहा था, वो थोड़ी सी कॉस्ट में इतना सब मिल रहा था. Now, at these kind of times, one has got to be very careful. Now, initially, I used to get bored, and I often thought that I'll only see the report of TSH. But then something told me that that is wrong. Because maybe if there is something lurking in the report, which the patient is not going to show to any doctor, and if I miss out on that, that would be a great problem. A patient of depression comes to me, I ask for TSH, serum TSH is normal. But somewhere lurking within those papers could be serum B12, which is say 80, 90, 100. And that could be causatively linked to his depression. So not only with a link to psychiatric illnesses, but I think it can become a medical legal issue. Like maybe you saw something else, you saw the CPK, it was highly raised, you didn't identify it, and then maybe you can land in soup because you were a doctor who has shown the report. So basically, what I mean is that sometimes we need to give adequate time, and there is no substitute for giving time to the patient. Always err on the side of underdiagnosis. It is easy later to updiagnose, which basically means that if you are not sure about the diagnosis, for example, is this patient a patient of bipolar disorder or it's only a recurrent depression? It's always safer to underdiagnose. Because if you diagnose the higher diagnosis, then that is likely to stay with the patient forever or maybe for a long, long time. And it's difficult to bring down the diagnosis later on because then the patient or the family could be unhappy that how could you diagnose bipolar when he was not. And there are times when these kind of things happen. Like, for example, a patient of recurrent depression comes to you. And while inquiring for mania or hypomania, you got a history that कि हाँ डॉक्टर साहब वो इस बार डिप्रेशन होने के पहले वो थोड़ा थोड़ा खुश थे 2-3 दिन और थोड़ा ज्यादा एक्टिव हो गए थे, एंड यू इमीडिएटली लेबल bipolar 2 disorder. But the reason patient was elated and a little overactive could simply be something that maybe he heard a great news and he was really happy over it for 1 or 2 days. So I think in such cases, it's better to underdiagnose, because as I mentioned here, I read a very good quote about it, that diagnosis should be written in pencil, which basically means that you should be able to erase the diagnosis as and when it demands. So not literally in pencil, but basically something that you can up-diagnose later on. Unless, of course, you are absolutely sure. Like in the very first meeting, if it's very clear that it is schizophrenia, which happens very commonly, I think then there's no problem. We know that there are multiple reasons for unreliability of psychiatric diagnosis. I mean, right from patient factors to clinician factors, diagnostic criteria, and so on. And I think it's always a good practice that in the first visit, we keep a provisional diagnosis and not really a final diagnosis, so that changes can be made later on. Use DSM, but don't worship it. Alan Francis, who was the editor of DSM-4, he said something very nice. I equally distrust clinicians who do not know DSM and those who know only DSM. I think that's wonderfully said. So if you believe completely in DSM, you're not willing to see outside it, then there's a problem. And if you don't know DSM at all, then you're not updated. You're not aware of the newer diagnostic categories or the criteria that are coming in. Now, with experience, with seniority, you start diagnosing things without using ICDs or DSMs. Like you might see a patient who has classical manic hyperactivity, over-talkativeness, elation, but he does not have that 4 out of 7 that the DSM demands. Now, it is prudent to still diagnose mania, even though the patient would not fit into exactly those criteria. Means for research purposes, maybe it may not be right, but not otherwise. I see especially junior psychiatrists or residents, especially in colleges, depending too much on the exact wordings of the DSM. I mean, for their stage of learning, it's fine. Unless you know the details of DSM or ICD, it's difficult to go ahead. But then with experience, I think it's important not to keep on worshipping DSM, but I think use your own experience also. Follow your patient, not your preconceived notion or textbook. There are psychiatrists who follow textbook to the T, in the sense that if the book says that you must not prescribe this combination, then you, this is not an advisable combination, then you strictly avoid it. Now, there are many caveats to what the textbooks say. And in fact, I'm sure, all of us see these kind of patients who come to us with a clinical history of, say, effects of the medication, which is quite unexpected. I distinctly remember that I have had patients of tardive dyskinesia who came to me before they had tardive, before the TD started. And then while giving history, they tell us कि डॉक्टर साहब जब से ये दवाई ऐड की है तब से ये मुंह का हिलना कम हो गया है, and the दवाई is Pacitane, Benzexol. Textbook says that when it's tardive dyskinesia, you withdraw anticholinergic drugs because I mean, cholinergic drugs improve TD, anticholinergic are supposed to worsen it. But then there are patients who report that otherwise. So I think in these kind of cases, instead of really sticking to the textbook, I think it's important to follow what the patient is showing, the kind of help that the patient is giving. Because you never know that what kind of evidence can crop. Because I also had this fixed idea that trihexyphenidyl cannot work in tardive dyskinesia, and it has to be withdrawn. Then I think there's a problem. Anurag, can you do this thing again? Muting everybody. I'll unmute myself. Yeah. Am I audible?
Yes, yes.
Yeah. I subsequently came across a research that says that biperidine is an anticholinergic, and that was shown to work in tardive dyskinesia. So the preconceived notion that anticholinergic must be withdrawn no longer stands, because then there are anticholinergics that still work in improving tardive dyskinesia. So it's very important that we follow what the patient is saying, try to see some grain of truth. I mean, of course, evaluate it. And if we think that it is going against what is being usually taught, I think one does not have to strictly follow what the literature says. De-prescribing requires much more skill than prescribing. I think this is something very important to remember. De-prescribing, that is bringing down the number of medications, bringing down the dose, is extremely important. One common problem that happens is the patient is going to one psychiatrist. From the first one, he comes to you, and you think that the treatment being given was not really appropriate, and you would like to change the treatment, and then you cut down on the previous drug, you start your own drugs. And very often the patients come back running saying, Dr. Saab, jab se wo dawai band ki hai, tab se condition ekdam bigad gayi hai. Now, this urge to stop what the previous one was giving and start your own thing, I think that has to be done rather patiently and wisely. Because whenever the patient has been maintained, may not be very successfully on certain drugs, I think it's very important that they be tapered down very slowly or cross-titrated with the drug that you want to give, as the case may be. But this de-prescribing should not be done, I mean, kind of hastily or rashly. And as the second statement says, applying it often to reduce harms caused by over-medication. I, for one, in every single visit of the patient, with every single prescription, try to see, okay, क्या मैं कोई medicines इस बार कम कर सकता हूँ क्या? Can I cut down on something? Can I cut down on the doses? Can I cut down on the number of drugs being given? Because we know over time, and especially when the patients are not responding to treatment, our own prescription becomes almost unrecognizable because the number of drugs gone piling up. A patient of schizophrenia not responding, you add a second one, then because the prolactin goes up, you add aripiprazole, and then things like that. So it goes on expanding. So it's also important to deflate the prescription. Learning about and using 3 treatments that are very effective but often underutilized. I've mentioned 3 names here. There can be many more, but I especially feel about these 3. Lithium is a fantastic drug, and decade after decade, algorithm after algorithm, guideline after guideline, lithium is topping the list of drugs for bipolar disorder. But for reasons which are not entirely clear, its use has come down significantly. And I see that especially in younger psychiatrists, they are somehow wary of using lithium. Reasons are there. Reasons are multiple, like lithium is seen as a toxic drug and it requires the serum lithium estimation and so on. But that's unfortunate because lithium is wonderful. In fact, in my personal experience, lithium is perhaps the only stand-alone mood stabilizer. I mean, I personally have not found Valpro to be standalone, carbamazepine to be standalone, but I have numerous patients who are on only lithium, not requiring a second drug for mood stabilization. Then clozapine. Clozapine also, I think, is being underutilized. Now, to tell you frankly, some doctors are overutilizing it. I mean, giving it at places where it is not really indicated as per the evidence available. Like starting off the patient on clozapine when treatment resistance has not been proven is not okay. And also not starting clozapine when the patient merits it. Like we do see prescriptions where the patient is getting, say, something like 20 milligrams of haloperidol and 8 milligrams of risperidone for 5 months, 6 months, and the family tells you, Dr. Saab, 5-6 months se koi farak nahi pada hai. I mean, why not start clozapine in these kind of cases? These exactly are the cases where the patient may do miraculously well at times with clozapine. I'm sure all of us have the experience of clozapine doing wonders in many patients. And thirdly, of course, ECT. Use of ECT has gone down. Now, this is something which is quite difficult to explain because experts, authorities often say that if there is one miracle in psychiatry, it is ECT. In fact, very amusingly, I have heard psychiatrists say with kind of pride कि मैंने तो ये आजकल ECT देना बंद कर दिया है. Now, I think बंद कर दिया है the person may have his or her own reasons, but I'm sure it's nothing to be proud about. You're not using a modality which is wonderful, which can work miracles. So if there are any young psychiatrists in the audience, I urge them to use these 3 treatments rather frequently, whenever indicated. When I'm seeing patients, I have gotten into this habit of intermittently asking myself, am I doing the best possible for this patient? And to my dismay, I often find that as I'm finishing the consultation, the answer to this question is no, I have not done my best. Because if I'm to do my best, I have to do the best possible psychoeducation, the best possible negotiation with the family, negotiation with the patient about whether he wants medication or not, whether he wants psychotherapy or whatever it is. So I think it will do us good and will do patient good if we keep on asking ourselves, कि मैं best possible कर रहा हूँ क्या? We need to remember that for every complex question, there is a simple reductionistic answer, and it is wrong. What is the cause of schizophrenia? Increased dopamine. If we stop at that, we are way off the mark. I mean, we know that with the current theories about the etiology of schizophrenia, there is much to be learned, much to be known. Maybe for telling the patient, that's fine. डॉक्टर साहब ये बीमारी क्यों हुई? क्योंकि वो ब्रेन में थोड़ा केमिकल्स का प्रॉब्लम होता है. I think from the patient's point of view, that kind of explanation is okay. But if we stop at that, I think we are not performing our duty of going into the current literature, reading as to what is the latest about it, updating ourselves. So I think we should be quite wary about these reductionistic answers in psychiatry. Because in psychiatry, as things stand today, things are complex in almost every area. Things are complex in the area of etiology, in the etiopathogenesis, in the management, etc. We are required to read scientific literature every now and then, but that should be read with healthy skepticism. Being a skeptic is important, and being a healthy skeptic is also important. One should not be a naysayer who kind of poo-poos or rubbishes whatever new is coming up. In fact, I've seen this tendency with some very senior psychiatrists who don't believe in anything new that's coming up. And I think that's I hope that I don't think so 10 years from today. Now, why read with skepticism? Most studies do not replicate. It's very important to remember that many studies that appear very significant, seem to be path-breaking, do not replicate. If they are done again by someone else, the findings are not replicated. In fact, some research has been done on this. It has been shown that more than 50 studies in psychiatry are not replicated. I think there's a lesson there that if we come across some study that touts one particular medication as a path-breaking medication, it's important to remember that it is one study. Has it been replicated? It's important to go in some details of that. Positive results are often exaggerated. This phenomenon is known as hyping. You hype the results. Positive results are often associated with adjectives like there's a robust evidence, there's a novel treatment, there was an unforeseen outcome of a study, and things like that. So always remember that if the results are positive, they are often exaggerated. And similarly, negative results are usually buried. We know this as publication bias, that studies that have negative results, they often do not get published because the editors don't want to publish something that does not have a positive outcome. So I think that's also very important. But we as a men of science know that even a negative result is very significant. It's very important to know if a particular drug does not work in a particular condition. So whenever going through literature, I think it's important to question everything. I remember Richard Feynman. Some of you might have heard of him. Richard Feynman was a very well-known physicist. He won the Nobel Prize for Physics sometime in 1960s. A wonderful, great teacher, great orator. He's called perhaps the best teacher of physics in the previous century. And he had said that question everything that you are being taught. Question everything that you are being taught. So I think there is some wisdom there. Like we should not take things as they come, but learn to question them. Learning from our teachers, but not following them slavishly. Now, we know that like genes, the prescription style also gets transmitted from teacher to student, and that could continue for a lifetime. So I think the teacher has taught you something, the teacher has taught you the basics, but it is not at all necessary to keep on following the exact prescription pattern that your teacher was using. And I think we all need to take the recent inputs, we all need to go through recent studies, we all need to learn of better combinations and better drugs that could be used in certain conditions. I recall this phrase by Samuel Johnson, who said that no man was ever great by imitation. After Kishore Kumar died, there was Kumar Sanu, there was Abhijit, but they could not be Kishore Kumar because they had reached that place by imitation. When Muhammad Rafi died, Shabbir Kumar came, Muhammad Aziz came, who were very much like him, would sing almost in his style, but they could not be great because they kind of tried to imitate their idol. I'm a firm believer that it's very important to read widely. And read what? Classic novels. Now, why read classic novels? It has always astounded me that some of the authors that I've read have a fantastic insight in the way the human mind works. Some authors write things with such degree of insight in their subjects that I often wonder that maybe even a clinical psychologist, a counseling psychologist, or a psychiatrist may not have thought of these kind of things, or may not have expressed the kind of things the way this author has. So I think classics, they do tell us about the human condition. They do tell us about the interpersonal issues and how people fight with the life, how people come out of adversities and so on. And it definitely helps us. Read non-fiction. I'm a big votary for reading non-fiction frequently. And the reasons for that are, I find that reading non-fiction, again, broadens your horizons significantly. You do not remain just a psychiatrist, but you become a psychiatrist who has much knowledge of the world. In fact, it also helps clinically at times. Like it has very commonly happened with me that if I'm reading on diverse topics, and I have patients who are in that particular profession that that is not, I mean, that's different naturally from my profession. Say the patient is an astrophysicist, and I have read something about astrophysics. Then it's very easy to form a rapport. It's very easy for the patient to start liking you because you have a liking in his subject. And so rapport formation, carrying the communication forward, that becomes much more easy. But perhaps the most important reason I advocate non-fiction is it broadens our horizons. It helps us see outside psychiatry. And thirdly, seeing psychologically astute movies and plays. It's very important to see movies which have psychiatry as a background. I'm very sorry, I made some recent changes in my slide, and unfortunately I had to change my device at the last moment. My desktop was not working, so I shifted to my laptop, and on my desktop I had put a photograph of Astu. Astu, I hope many of you have seen this movie. For those who have not, Astu is a movie on dementia in which Agashe sir has wonderfully portrayed the role of a patient of dementia. when you see these movies, then you get to know better the kind of hardships that are faced by the patient, the kind of hardships that are faced by the relatives. When we are sitting in the confines of our clinic or chamber, we keep on implementing what our textbook tells us, what the journals tell us, some idea that we have, and we keep on translating that into the treatment suggestions. But then watching movies like this, you are get very close to, say, having such a patient in your own home, because then you know what the difficulties are that a daughter faces. Like in Astu, Dr. Mohan Agashe's the character that he has played, his daughter, the kind of hardships he has faced in tracing him. He gets lost, and where does he go, and how does he find his way, or does not find his way, and so on. So I think this kind of a rounded approach to life, a rounded approach to the kind of inputs that you keep on getting, apart from the books on mental health, I think that makes us a better psychiatrist. Traveling the world to understand the diversity of human experience. Traveling helps greatly. I think those of us who have gone abroad, maybe visited multiple countries, would vouch for the fact that seeing people from different countries, seeing their way of thinking, seeing their cognitive style, I think that adds much to our own perception of the condition of our patients. I can tell you that my father was in central government service. And because he was in central government, we were transferred every 2 or 3 years all over the country. And so I had my schooling in Delhi, I had my schooling in Calcutta, then I had my schooling in Nagpur. And the way it helped me was I learned Punjabi, I learned to speak Bangla, which I can read and write. And it broadened my horizons about the different kinds of personalities that come from different places. Like the typical Delhi personality is much different from the typical Calcutta personality, which is much different from the typical Nagpur personality. I mean, we have these median personalities in every community, every geographical area. And if you are well traveled, then you have a better grasp of different cultures. You develop better empathy for cultures which are not your own. You develop more empathy for thinking styles which are not like your own. So I think that's a very valuable experience. And I think whenever the opportunity presents itself, I think if not go to different countries, at least visit places in the country which have different cultures, trying to learn about the cultures. Not losing touch with psychotherapy. I think it's extremely unfortunate that psychotherapy is slowly getting buried in, let me call it, the avalanche of neurobiology. These days, neurobiology has become the area of focus. It is the thing which is taught to psychiatry PGs in medical colleges, and psychiatrists quite uncommonly discuss the recent advances in psychotherapy, or even teach psychotherapy to the students. I remember when I was at PGI Chandigarh, I don't know if the tradition still continues, we had to finish 100 psychotherapy hours before we were allowed to appear for MD. Now, that was something very unique about my institution, that 100 psychotherapy hours. And the way it was ensured by the faculty was that we had to submit these 100 receipts to the faculty. Let's see, this is the proof that I have done psychotherapy with 100 patients. We had to request the patient to give us the receipt and then hand it over. Now, that kind of teaching is largely missing in the medical colleges these days. And I think that is the prime reason why the young psychiatrists who are coming out know of psychotherapy only through what the textbook says about CBT, about REBT, maybe a few words on Sigmund Freud, but not beyond that, not much when it comes to the practical aspects or actually doing it. Now, I had read somewhere that this patient complained that it's all about writing prescriptions for medications and the days of tell me about your mother are long gone. Now, this patient was an author. I'm forgetting the name, but I think he has put it so well. The days of tell me about your mother, they are no longer there. Now, tell me whether you are hearing voices or not. Do you think that people are trying to harm you? I think we have got limited to these kind of questions. I remember CMC Vellore had Professor K.A. Kuruvilla when I was doing MD. He was the professor there. He often used to come to us as examiner. And sometime around 1990, he gave the DLN Murti Rao oration. Dr. Kurvila, a very famous name, was an expert in behavior modification. And in his oration, he said something which I remember verbatim because of the power of those words. And I've quoted him here, that what distinguishes us from other medical specialists is our ability to cure the patient through only talking. It would be sad if we lose this tool. I think these are words of great wisdom. That's one way, or that's say the major way we differ from, say, physician or a surgeon, because by merely talking we can cure many of the patients. And as he very rightly says, it's very sad if we lose that very important tool in our armamentarium of the treatment modalities available. Being a vocal advocate for the mentally ill. I think that's very important. Now, again, there is some mishmash in my slides here, but I shown the slide of mental hai kya. I think 1.5 to 2 years back, we had this big issue of a new movie with Kangana Ranaut and Rajkumar Rao, which had the title Mental Hai Kya. And very appropriately and very courageously, our then president, Dr. Ruresh Vaishnav, and his entire team, they went tooth and nail behind this. They fought in the court and they got the title changed to Judgmental Hai Kya. I'm sure, I mean, many of you know this. So I think that's a kind of advocacy that we need to do for our mentally ill patients. And there can be numerous examples where we need to come to the rescue of mentally ill patients in the public eye, because we know that what really happens through a psychiatric patient is beyond his control. He does not have to be stigmatized. He should be treated with compassion and so on. And of course, helping the mentally ill in the community. Now, talking of greatness, this slide and the next slide are about greatness. The earlier ones were maybe how can one become a better psychiatrist, but in my opinion, greatness lies in this slide and the next one. I mean, the idea of greatness is something which can often be subjective. Like everyone can think of something as being great. Someone might say that a great teacher of psychiatry, a wonderful teacher is a great psychiatrist. Someone might say great researcher is a great psychiatrist. But my idea is, one of the ideas that a person who helps the community, mentally ill in the community, I think if he does to a very significant extent, I think that is something that I would call as great. Now, when I say that, one of the prime examples in front of me is Dr. Bhattwani. We all know the Maxis Award winner. I often think that he is the kind of psychiatrist whose photo should be put in the puja room. I mean, who can rescue 7,000, more than 7,000 mentally ill destitutes roaming the streets? I think that's a humongous task, a superhuman task that he has done. And I think that's the kind of psychiatrist that we need to call a great psychiatrist. I mean, I do not know how much of reading does he do. I don't know if he reads journals. In fact, he very courageously told once on the mic that I had not read Mental Health Act. I have not read MSCA 17 because I do not think I need it. And though not keeping abreast with the latest developments in psychiatry, he has helped patients in a way that very, very few can match. So I think that is greatness for me. Or my very close friend, Dr. Anand Nagri. Dr. Anand Nagri has community psychiatry written all over him from head to foot. I mean, the number of community programs he has completely devoted himself. Swatala wahon घेतलंय in community psychiatry. Absolutely no financial selfish gains anywhere in sight. But I mean, the kind of programs that he runs, the number of programs that he runs, I'm sure all of you are perhaps aware of the work that he is doing through the institution founded by him, Institute for Psychological Health, Thane, IPH. My very dear friend from Nagpur, Dr. Avinas, he has worked wonderfully in the community by I think some of you might be aware that he has created the first website probably in the world where mentally ill people can find their matches for marriage. He has opened a school for mentally handicapped children. He was running a suicide helpline for quite a few years, and many more things. So I think for me, therein lies the greatness. Means if you can come out of the confines of your chamber, if you can reach out to the community, if you do something which is out of the ordinary, where you have to go out of the way to good work, to do good work. I mean, you being called to a school, ki, sir, please come to our school, please talk to the students on this topic, and you going there and talking to the students. I mean, yeah, that's fine. That is helping some people. But then maybe you're not going out of your, you are being called, you are being invited. आप देखते हो कि आपकी डायरी में बैठ रहा है कि नहीं, बैठ रहा है तो चले जाएं, टॉक दे देंगे. साल में 50 टॉक्स दे दिए. But then greatness lies in coming out of the comfort zone. Greatness lies in compromising your own comfort, compromising your own income, compromising your own personal time, maybe the time that you were giving to the family, that could be, you could be cutting down on that. So I think therein lies the greatness. And on my thoughts on the second aspect of greatness is being active in scientific research, especially the unanswered questions. Mental health has been changed by people who very rigorously were into research, did the kind of research that changed the face of psychiatry. I think you all know these people. Just to recap, beginning from upper left corner, Aaron Beck, father of CBT, then Michael Retter on his right side, the father of child psychiatry, who did huge amount of research. In fact, he completely changed the face of child psychiatry. And he is the one who single-handedly is responsible for making child psychiatry as a subspecialty all over the world. I think that's a fantastic job, and largely through very good quality research. Now, very unfortunately, we have lost both these stalwarts, Aaron Beck and Michael Retter, only a few months back in a single year. Below him, you find Eric Kandel. Eric Kandel, by the way, is only the second and till date the last psychiatrist to get the Nobel Prize. The first, as we all know, was Wagner Joring, who got it for the malarial therapy. And Eric Kandel got it a few years back for the molecular basis of memory. And on his left is John Cade, whose path-breaking research on lithium brought lithium into mainstream. So I think doing meticulous research on topics which are not often explored and finding things painstakingly that can change the face of psychiatry forever. I think that's again a hallmark of greatness. And finally, I would end with the famous statement of Hippocrates, primum non nocere. First, do no harm. I mean, that's not really a sign of greatness, but that's a sign of a good psychiatrist, that whenever we are seeing patients, it's very important to see कि मैं मामले को ज़्यादा बिगाड़ तो नहीं रहा हूँ. In trying to help the patient, is it that things are getting worsened in some way, maybe even subjective for the patient? So, friends, with these words, I would like to end here. And thanks a lot for your patient listening. Thanks a lot for this wonderful opportunity. Thank you.
Thank you, sir. It was a really wonderful session. I will ask first question. By that time, Smita madam will compile the questions. Sir, how to do time management to do all these things? Because to be a good psychiatrist, to be a great psychiatrist, it needs multitasking. So how should one manage the time?
Yeah. See, I think that's a very important question. Now, in doing my own personal time management, I look for two things. One, is what I am doing adding value to my life? If yes, I go for it. And secondly, if I'm doing something, is it really something that I have to do and something that I can't avoid? Because if the answer is yes to both the questions and you are doing either of these, then I think the time management is good. if we look at our 24-day schedule, like one could take this as a homework, like just plot as to after getting up at 6:30 a.m. in the morning yesterday till 11 p.m. at night when I went to the bed, when did I do what, and just try to see for yourself कि इसमें से कुछ कम हो सकता था क्या? Will you have cut down on something? And I'm sure you can find that there are multiple areas that you can cut down. I mean, you can definitely cut down on the time that you have spent on the social media, or maybe you can cut down on that longish phone call that you had with your friend, and so on. I know of very good doctors who have not taken to WhatsApp at all. They've not downloaded WhatsApp on their phone. I'm not saying that WhatsApp is all bad, but then that is time management. You realize as to what's going to really further your cause or someone else's cause and cut down the rest. I think that's a general guiding principle. Bhalchandra, just a few moments more in answering that question. I had read somewhere a very good concept that imagine that it's your funeral. Okay? Imagine that it's your funeral. जो अपने सगे संबंधी हैं, they are all at the funeral ground. You have been cremated, and someone is giving a speech on you. And what would you like that person to speak about you? That becomes the guiding principle of your life. Like if you would like that person to say that, like for example, me, that Dr. Bhave helped the needy. He was very kind and compassionate, never refusing help to anyone who came to him. He was very kind to animals. So now, the way I'm managing my time, is it in the furtherance of those values? And I think therein lies the secret of identifying as to which are my values, which are the things that I would like to develop in my life, and then devoting more time to them than things that don't further that.
Yeah. Yes, sir, absolutely. So I think it would give motivation from inside to manage the pain. Yeah. Smita madam, please go ahead with the questions from your side.
Yes. Dr. Bhave sir, many people have greeted you in the messages and complimented, and I could see, and I could see, I think 2 names of great psychiatrists you have mentioned. I could see Dr. Anand Nagri sir as well as Dr. Avinas Joshi. So that's a compliment to you. I think they have they have been there for your lecture.
I'm glad that they are here.
And so it was really an engrossing lecture. There are a lot of questions and messages. I will just try to ask the important ones, which I feel.
Smita,
yes, sir.
10:30 p.m. is my Netflix time. So better.
Okay. Yes, definitely. So we will try to do it in next 15 minutes. So this is from, I think, young psychiatrist, Dr. Nidhi Jain. Should we write diagnosis on prescription?
We should not. We should not.
Yeah.
I think there are many reasons for that. I think the foremost reason is, I would say 2 reasons, or rather 3. One is that it does not remain confidential anymore. The prescription goes to the chemist, and every boy at the chemist shop can see that you have got schizophrenia. Sometimes we do not want the patient to know the diagnosis, because in these days of Google Doctor, we know letting the patient know a sinister diagnosis can have negative consequences. Because I think many of us, we kind of give wishy-washy answers when asked about the diagnosis, which is right. Like a patient of schizophrenia says, "Doctor साहब, मेरी बीमारी को क्या कहते हैं?" I think it's better to say कि इसको psychotic illness कहते हैं than saying that you have schizophrenia. Because in all probability, he'll go back, he'll Google it, and then he'll disagree with your diagnosis, he'll stop coming to you. So okay, I think, I never write down the diagnosis on that. And secondly, thirdly, as I said, the possibility of down diagnosing does not remain anymore once you put that on the paper. Even if you revise your diagnosis later on, there is a paper with your signature on that speaks about the diagnosis. So I think that should not happen.
Okay. From Dr. Nishikant Vibhute, what should be our approach to patients who are defaulters or with repetitive pattern?
I'll tell you my approach. My approach is to ask about the reason for the default. When we ask about it, we should be completely non-judgmental. We should not show any kind of negative emotion on our faces, because patients can have completely understandable reasons for defaulting. Like say a poor patient who defaults because he does not have the money to come to you, or who simply does not have the money to buy medication. But if you have kind of aggressive stance, he may not open up about that. So I think first it's very important to know as to why the defaulting occurred. I think that's a common rule for non-compliance that we all know. That in case of non-compliance, the first question should be the reasons for non-compliance. We must know the reasons without being judgmental about it. And secondly, trying best to see as to what you can do so that the same reason does not crop up, at least from your side. Like if the patient says कि डॉक्टर साहब वो आपने दवा दी, मेरे को तो बहुत 3 दिन में सोया रहा, इससे फिर मैं एक साल तक आया ही नहीं. So now there is a lesson for us. Now we know that maybe we need to be more careful about the sedative potential of the medicine that we are giving. So I think a non-judgmental inquiry, and secondly, trying to see what best you can do so that at least from your side, you are taking due precautions so that the default does not occur. Ultimately, it's not in your hands. Patients are careless, families are careless. There could be umpteen undesirable reasons for default.
Okay, sir. Dr. Dhananjay Ashturkar has asked, sir, how your artistic inclinations help you to become a better psychiatrist?
Thanks, Dhananjay, for this wonderful question. Now, I think the answer to that is manifold. One, now I think some of you know that I sing. I love singing and I sing. And my own style is that whenever I am humming, like in my bathroom, when I'm taking bath, I hum very loudly. It's not humming, I sing very loudly. And while singing loudly, I enter into the mind of either Mohammad Rafi or the hero on the screen who sang the song, or whichever singer it is. And that helps me identify the different kinds of emotions that I personally have not experienced in my life. Just for example, like in this movie, what was that? Aaye Din Bahar Ke, Dharmendra singing, Mere Dushman Tu Meri Dosti Ko Tarse. He's accusing the heroine left and right and abusing her. That's the kind of emotion that I do not recall having felt for anyone. But when I'm singing that song from the point of view of the lyricist who wrote it, I think that broadens my horizon about the kind of emotionality human beings have. That's one thing. And secondly, that gives me a wonderful window to discuss something with the patient. Like if the patient says, I ask the patient, tumhari hobbies kya hain? And the girl says, singing. So I said, okay, whom do you like? And then by chance she says, Mohammad Rafi. I said, wow, wonderful. I mean, tum to hamare Iraq ke singer ka naam le rahi ho. Which songs of Rafi do you like? So when you strike that kind of conversation about maybe light music or classical music or musical instruments or composers, I think in one of my slides, I had said that forming therapeutic alliance both outside clinical psychiatry, but then it definitely kind of cements your bond with the patient. So I think I can think of at least these two ways it has helped me.
Okay, sir. Again, related to diagnosis, Dr. Anu Prathi has asked, can we not write the DSM code for diagnosis as we may not remember the patient, something like that?
Yeah, I think it's not a bad idea. We can write that. But there's one small problem I see there, that it would still be easy for the patient to go and type the DSM code on Google. And maybe it can throw up the diagnosis that we have in mind. I mean, for psychiatrists who keep records, and I believe that everyone should, it's always a better idea to keep the diagnosis in our records. Like I have the record of every patient that I've seen since 1986. And so whenever I need to look at the diagnosis, I simply have to go back to my record. So I think mentioning the diagnosis on your record is perhaps the best thing. And maybe the second best could be using the code. Yeah, if you do not have records.
Okay, I think your slide about reading was very nostalgic to a lot of people. So people have asked about list of non-fiction and things to see. And
I think something which is very, very personal. I mean, it's very subjective, very personal. I might think the book by astrophysics for people in a hurry by Neil deGrasse Tyson is wonderful. I mean, it gives wonderfully well the entire astrophysics in one small volume, and I might recommend it to my friend. But my intelligent, well-read, erudite friend may not find it appealing.
Right.
That is something which is very subjective, and there can be no generalizations. So I think anything about which you have a passion, and I do believe that most of us, we have passions outside psychiatry. Many patients tell me, "Doctor साहब, मेरी तो कोई हॉबी है नहीं." So the question I ask them is कि अच्छा, आप स्कूल में जब थे तब किन किन बातों में अच्छे थे? क्राफ्ट वर्क में अच्छे थे क्या? ड्राइंग में अच्छे थे क्या? एंड देन द पेशेंट कम्स आउट, हाँ डॉक्टर साहब, मेरे को सिंगिंग में हमेशा वो फ्रंट रो में रखा जाता था, तो क्योंकि मैं अच्छा गाता था. So then you know that he has some area of interest outside his profession. So I think it's that way. I mean, look at your own passion, follow it, but follow you must. I think it's very, very important. My own experience tells me that the more I read outside psychiatry, I think the wiser I become. I can't be very sure, but that's what I think.
Great. Last question. Like you said, it's always better to underdiagnose patients. Similarly, undertreating, that is below therapeutic dose, how much is it beneficial?
Underdiagnosing cannot be equated with undertreating. I mean, why undertreat? I think treatment is very important. In fact, there are patients who require very high doses. When you give valproate for mania, you can't give something like 400 mg or 600 mg. You know, the therapeutic dose is upwards of 1000 milligrams. So I think in the one wonderful part about psychiatry is that being a part of science, everything is well documented, fairly well evidenced, and we have guidelines for things. So I think, I mean, the least effective dose is a good concept. Like you start with the least effective dose and then up-titrate it. I think that should be the guiding principle for all psychopharmacology.
Okay. So maybe this one more question we can take. Again, Dr. Dhananjay Ashturkur has said we come across many psychiatrists who are not much academically or clinically versed, but have great bond with patients and have flooding OPD. So how to become a good psychiatrist is something out of the book or curriculum. And I think you highlighted that. Maybe you can comment on this.
One thing is that you could get very good results even without reading the latest. Like my professor of psychiatry who was in action 30 years back, I mean, if the present patient goes to him, he could do quite well. I mean, he could use trifluparacin in adequate doses and maybe lead a schizophrenia patient to complete remission. But then it does not harm at all to keep abreast of the recent thing, because, you know, I mean, it's, it does not even need any validation. That being updated with the latest is very important, because science always improves. Science never proves or disproves, but science always improves. So I think all research that comes on in subsequent years or subsequent decades, it is an improvement on the previous one. When we have second generation antipsychotics, maybe we have some absolutely new antipsychotic, it is likely to be an improvement on the previous one. So I mean, you could do well, you could be a very famous psychiatrist, maybe you have excellent communication skills, you have not read the recent textbook or the recent journals, but you have excellent communication skills, you have got good clinical acumen, so you could do well. I mean, Smita, you talked about having a flooded OPD.
What?
The term used? A flooded OPD or something.
Flooded OPD. The question was like that.
Now, a large number of patients does not translate into a great psychiatrist. Not even a good psychiatrist.
Yes.
Someone who is practically successful. I mean, he is the kind of psychiatrist who has flooded OPD. Of course, great psychiatrists, good psychiatrists, excellent psychiatrists can also have very large number of patients. But then only large number of patients can be no criterion for judging the proficiency of a professional.
Okay.
Yes, sir. What way, sir, is it?
Okay.
Can I ask one question?
Yes, sir.
It's not a question, it's a comment. You have already emphasized so well about so many things, and most of them were take-home messages. But for me, for young practicing clinicians or clinical psychiatrists who are doing day-to-day work in psychiatry, the most important take-home message was the comment here you made about underutilized treatments, namely lithium, clozapine, and ECT. I think it was very, very essential for youngsters to know that these treatments are underutilized. We all know now that you need not wait to start or introduce clozapine till the patient becomes chronic. It's not a treatment for chronic schizophrenia. People now advocate, even in the first episode, if you are sure of diagnosis, you can start clozapine because it's a gold standard. Similarly, use of ECT, don't wait. Don't be feel don't feel proud that I have not used ECT for 6 years or 9 years or 10 years. No, you are depriving the patient of the one of the most cost-effective treatment in psychiatry. And of course, lithium people are using, but it has gone into background because of the other mood stabilizer. But still, lithium is the best as a mood stabilizer, as resistant depression, augmentation, and so many things. This I would compare, I'll finish it. The neurologists, neurologists, they use initially for Parkinson's disease, they start with trihexyphenidyl, then amantadine, then ropinirole, then pramipexole and whatnot. The neurological thinking today, the neurologists, the people who are reading well, attending well, they are of the opinion that you should start first thing with the Sindopa. Sindopa, don't wait. I know there are some Sindopa, but these drugs, especially pramipexole, ropinirole, are all hype drugs. They were all German drugs, and there's a big articles saying that they're least effective or in fact more costlier and more having side effects. So as neurologists feel that for Parkinson's disease, first instance you start with Sindopa. Don't wait with trihexyphenidyl and amantadine, etc. Now there are many neurologists I have seen, they use everything. They use Sindopa, amantadine, pramipexole, ropinirole, and trihexyphenidyl. It's not correct. It's not correct. It will give you more side effects than actual effect, and will land your patient into side effects. I think something like neurologists, we should start using more lithium, clozapine, and ECT. Thank you very much, and thanks for this slide.
Okay, sir. So I think with this, it's 10:20. We have come towards the end of this engrossing and wonderful session. May I request Dr. Agashe, sir, to
I think
give the... Okay.
Yeah. He has come.
Is Agashe, sir, not there?
No, ma'am. I think he's not. He's just left.
Yeah. So, Dr.
Okay, since we are aware that sir is not well, there is some technical issue also going on. So I request Dr. Bhalchandra to go ahead with the next part.
Yeah. So my responsibility is to give a vote of thanks. I thank Dr. Sudhir Bhave, sir, for a wonderful session. Agashe, sir, for being a chairperson for this session, and Smita madam for moderating the session. I thank Swati Doshi ma'am and Jyoti Shetty madam for welcoming all the delegates, whole team of IPS and PPA for giving us opportunity to organize this webinar, that is a Pulse of Wisdom. I thank all senior friends for being audience. Finally, I thank Altius team, Mr. Anurag Srivastava, for giving us a technical support and providing us as an academic partner as usual. Now I hand over session to the Anurag Srivastava, sir, for his final remarks.
Thank you, sir. First of all, I feel privileged that so much of stalwarts of psychiatry, with whom I have grown in last 22, 23 years, they're all in front of me, and I have what I am today because of all, sir. So thank you very much, sir. I thank IPS Pune branch and PPA for giving this wonderful opportunity to be part of this academic extravaganza. I would like to thank Dr. Sudhir Bhave, sir. Not for academic, but listening you itself, sir, is an honor. So thank you very much, sir. I feel privileged that I am part of this, and I got the opportunity to be a part of this program for this insight, wonderful presentation. I'm sure people sitting across have got good amount of learning, and I thank again on behalf of all of us, sir. I also would like to thank the medical fraternity who have present here, and I'm sure knowledge gathered today is will be very useful tomorrow and in your day-to-day practice. And thank you very much for attending the program. And on behalf of RTS Biogenics, RTS Biogenics people will meet you timely and bring such good programs in future as well. Do support us the way you support us, and we will definitely thanking you for all your support. And thanking again once again. I wish each one of you a safe and to take care of yourself and your loved ones. And happy New Year to all of you, and happy Makar Sankranti. Thank you so much, sir. Thank you for giving this opportunity.
Thank you so much.
Thank you. And good night, sir.
Thank you, sir. Good night.
Good night to all. And thanks to all.
Yeah.
Thank you.
Yeah, you can stop the recording.
Yes, sir.
Yeah. Okay. Yeah.